Good evening, ladies and gentlemen. Welcome to Dental XP. I would like to take this opportunity to thank Dental XP for the invitation to come and lecture again. It truly is an honor to be with guys that are so innovative and so trailblazing in the world of dental education, and really phenomenal. So thank you very much. It's really a pleasure for me to be here. What I'm going to be talking about tonight is the controversies surrounding delayed versus immediate implant placement. And the question is there a middle ground? So the question, to place or not to place, I think that's the critical one at the moment, because what we have at this point in time two schools. You've got the one school which is immediate placing everything, and you've got the other school which is telling us to hold back. Whoa, stop. We've got to start thinking about this, and we mustn't be immediate loading at all anymore. We should be doing everything delayed. What I want to do tonight is look at the literature, look at the data, also share some of my experiences, and maybe try and give you something that basically gives you a little bit of an idea of how to have a middle road, where maybe we need to look at the way we're doing things, maybe we need to change things a little bit, maybe we also need to just adjust some of our techniques. And we're going to go through that tonight to try and show you exactly what's going on. Before we start, I think the important thing to do is to go through classification, and Chen and Boozer and Hammerly in 2004 put forward this classification just to make sure that we're all on the same page when it comes to the placement classification. And if we have a look at the slide, you can see here we've got type 1, which is immediate placement. And immediate placement is an extraction socket with no healing of bone or soft tissue. And that's essentially the one that we're talking about most. Type 2 is early placement, 4 to 8 weeks, where there's some healing of bone and soft tissue. Type 3, which is early placement, 12 to 16 weeks, where there's post-extraction healing and extensive and significant bone healing. And type 4, which is late placement, 6 months plus, which is a fully healed socket. We are basically going to be talking about type 1 and type 2, the immediate placement versus the delayed placement on the other side. Now, let's look firstly at the success rate of immediate placement, because is it something that we can be doing? And if we look at the systematic review, and I think it's important to note that when we're looking at data, systematic reviews and meta-analyses are two of the highest rated data that we can look at. Therefore, I've taken the systematic review by two very prominent researchers, Stephen Chen and Daniel Boozer, who did this in 2009, was published in JOMI, and they looked at around 54 studies. And of the 54 studies, they found that 35 of the studies had a mean 99% survival, which is a very, very high survival rate for implants placed with immediate protocols. 25 of those studies had 95% survival or higher, and there were 3 studies which were greater than 5 years, which is really a long follow-up, with a 95% survival rate, which is absolutely phenomenal. Now, from this, we can see that there's no debate that immediate placement works. But the thing is that what they were measuring in a lot of these studies, they were measuring only the functional effects. So in other words, were they functioning very, very well? And the answer was, in 95 to 99% of the cases, yes, it's something that works extremely well. There's no debate about it. So that's why we have to start looking. Do we stop doing this altogether with something that was working so well? And really, what are the problems? Why is everybody telling us that we have to stop doing immediate placement? Here you can see this case just to show you how we actually did the protocol. And just to go through a little bit of a case presentation and just to show you how I like to do things. Here's a case where we had a tooth which was traumatized, had a long time ago, had an external root resorption. You can see the pink shining through. And what I like to do in these cases is I like to do what I call a walkout as you walk in, where we extract the tooth and we put the implant in. And we basically retrofit the patient's own crown, whichever it is, whether it's ceramic, whether it's a ceramo metal, or patient's own tooth, which is even more ideal. And we basically place the crown back onto the implant, retrofit it, to help to stabilize the soft tissue around the papilla and the buccal tissue. You can see with healing, you can see on this slide on the left-hand side where there was a little bit of recession. And what we did to try and fix that recession was not do any grafting. What we actually did was we took the temporary off and we concaved the underlying part to allow the soft tissue to fall down, so that when we came to the final, you can actually see we had a better situation 1 to 1.5 years later. We were almost in the exact correct position of the gingiva in that case. So it's a very important thing and a way that I like to work it. for the pure reason, and I'll explain a little bit later when we get to get to some further details at a later slide. So what are the benefits of immediate placement? And one of the biggest benefits of immediate placement is single placement. And here you can see this type of scenario where a patient needs an implant. If you go to a patient and you go to 2 surgeries and you say to one patient, well, I'm going to extract the tooth, I'm going to wait 8 weeks for healing, and then I'm going to place an implant, maybe do a little bit of bone grafting, then I'll come back, I'll do an exposure, and all in all it'll take you about 8 months and maybe 2-3 procedures. Versus coming down the road and they come to my practice and I say, no, not a problem, I'm going to take out your tooth, I'm going to put a crown back on immediately, and you're going to have your implants. It's going to be one procedure. 3 months later, you'll have your final crown done and dusted. And I think essentially, who's going to go to the first guy? There's no debate that anybody in their right mind is going to say, well, if I can get the same result doing it immediately, why not do it immediately? And there's no debate that a single procedure is what patients really want. It allows the immediate restoration. And here you can see the kind of scenario whereby we've done the immediate restoration. Now, again, I said to you before that I like to put the patient's own crown back. Now, the first thing that you might say to me that is this guy an absolute lunatic for the pure reason that, have you seen what the crown looks like? It looks like the dog's breakfast. There's a very good reason why I put the patient's own crown, even if the crown doesn't look great. And one of the main reasons for that is that if the patient has their own crown for 20 years and you put that same crown back, when they look in the mirror and they see the same crown, they think, okay, well, that's not a problem because not the permanent. But that's what I've been walking around with. So is it really a problem for them? And the answer is not. The other thing as well is that in their minds, it becomes a much smaller procedure because when they look at it in the mirror, and they do one of these guys where they're looking at it in a big mirror, and they've usually got these big mirrors in the bathroom which magnify everything perfectly, and they look and they think, well, actually, what's been done here? There's nothing actually been done. So it's not really a problem. And it makes the procedure that much smaller for them. So it's much less traumatic because of this. Because of these things, we get a much less traumatic situation. And here you can see again, with convexing the whole, with concavity, with the undermining the underlying part of the crown here to create a concavity there, we actually managed to take the gingival level from there and actually bring it down by making a concave underneath the crown. So there's far less surgical time in these cases. There's far less bleeding because of the fact that we're stabilizing the soft tissues and the clots. And also what we're doing is we're stabilizing the papilla, more importantly, in multiple situations. And here you can see in a case where we didn't have primary stability for immediate provisionalization. So what we did is we customized our abutments, and the customization of our abutments allowed the papillae to stay in place, because essentially the gum doesn't know that whether there's an implant or whether there's tooth or whether there's a custom abutment there. As long as there's a contact point, it's going to be happy and it will remain intact. And here you can see the same case I think this is about 4 months later. You can see the perfect architecture being maintained and the papilla, most importantly, that's been maintained in this case. And here you can see the phenomenal result that we achieved that really is an absolute award winner. I do, however, have to say that we are going to look at this case a little bit more closely a little bit later, because this gives us the exact example of why people are saying don't do immediate placement. There's also reduced post-operative pain, reduced need for analgesics, reduced duration of pain, and less cost. These come from Fortin in 2006 and Nekenki in 2007. So with all these factors in place, one has to question why, in God's name, do we want to change the procedure? Why do we now want to say, hold on a second, let's not do immediate placement anymore, let's do delayed. We mustn't do immediate placement anymore. And there's a very good reason for that. The problem comes down to long-term aesthetic stability. And anyone who goes to a lot of conferences, you'll know that this is the biggest buzzword there is around. Long-term aesthetic stability is one of the biggest problems. And the first one that we have to deal with is buccal recession. And this is often a scenario where we get a type of situation like this, where the patient comes back 6 months later and they've got some recession over there, or with the final crown in place. And this tooth here, you can see the type of recession that they've got over there. And these are real problems for patients. Now, if you haven't sat down and really discussed with the patient, said, listen, we're going to get some recession, and these are patients with high aesthetic values, high lip lines, where this is absolutely critical that their smile is 100% perfect, you are going to have some major problems if this is what it ends up as. When it starts out looking perfect and 6 months later this is what it's starting to look like, you've got a potential court case on your hands. So we want to try and prevent this from happening in the kind of cases where it can happen. The second thing that is a real problem, also long-term aesthetic stability, is the collapse of the buccopalatal dimension. And as you can see in the slide on the left, you can see here that the loss of the tooth means, and the loss of the root means that you've lost the buccopalatal dimension collapses, and you lose the root prominence, which is normally overlying here. And you can see on the slide on the right also the type of concavity that one gets. Now what this does is this kind of scenario on the left-hand side, you can see now when this patient came back about 8 months later, here again we retrofitted their crown. This is a provisional, and they're now ready for placement. But if you look on the left-hand side, you can see there's discoloration of the gingiva in this area. The first thing that springs to mind in this kind of scenario is, hold on a second, is there something wrong here? Because you can see the gum there is nice and pink, the gum here is looking a little bit red. The thing is, the gum there is not red at all. If one takes a different angle, or if one takes the flash away, this will be just as pink. The problem here is that you now, because of the buccopalatal collapse, you now have different light reflection properties because of the loss of that root prominence. So you are dealing with a concavity versus a convexity, and as a result of that, the light reflection properties are different. And with that implant in position there, you now have the scenario on the right where when a patient smiles, you can start to see this dark grey shadow underlying the lip, and with higher lip lines, it's even more prominent in these cases. And it's often the first wedding photo or some photo that they've been out to with a friend, whereby they come back and they say, whoa, hold on a second, there's something wrong. I can see the implant shining through. And it's not the implant shining through, but it's more the greyness of the shadow that comes because of the different light reflection properties. And again, this becomes a huge problem for the patients and something we need to know about, and we need to discuss with our patients from the start so that we understand that there might be this problem. So let's look at that case report and let's see what happened in this case. Now again, you can see the kind of scenario that we've got. Beautiful results. Maybe we could have done the crowns a little bit more translucently. But 6 months later, the patient came back, and you can already see what's happening with the buccopalatal dimension collapse. And let's look and see here. Whoa, what's happening here? We're starting to get recession. We're starting to get buccopalatal collapse. The frenum's becoming a lot more active. The one thing that we do know that's a very positive sign is notice how the papilla is still intact here. And that's a critical issue in this. 1 year later, and now it's an absolute disaster. An absolute disaster, because we look at this, we look at the amount of recession. Now you can look here, we used wide diameter implants. At those days, that's what we used, and we'll talk about that a little bit later. And we've also got massive recession. The frenum is still here, but again, the papilla is still intact. And the fact that the papilla was still there, we know from Miller, with his classification, if the papilla is still intact, we can fix the case. This case took me 2 years of rehabilitation at my own cost to repair. And you can see the first thing we started doing was change from metal abutments to zirconium abutments. We platform switched because we knew at that stage we had now platform switched. And here you can see as well the first thickening up of the gum. We did the multiple gum grafts. The first one was a tunnel technique to repair this. And you can see after there you can see the second connective tissue graft coming there with coronal repositioning of the flaps. And you can see after 2 years you can see what we had. We had now got it to not a perfect result, there's no debate about that, and we're never going to get a perfect result, but taking back from where we went with the frenectomy, from where we've come to where we are, a much better result. And we eventually got her back 6 years later. This was finished in 2006, and here we can see the case 6 years post-op. And again, the soft tissue is there. That's the most important thing, and that's really what I want to show you here. But what I also want to show you is how unaesthetic the soft tissue is. Luckily, with age, this patient's lip has dropped a little bit, and she doesn't have that high lip line. My thoughts were, do I come here and do some laser rehabilitation and make it look a little bit prettier? But the fact that I've got such thick soft tissue here, I'm actually more inclined just to leave it. The patient's happy, and just for me to get better photos, just so that I've got to do laser just to get better photos, is maybe not the right way to go. So we did manage to rehabilitate it, but this is the kind of problem that we might be dealing with, and that you might be dealing with when you have these type of cases. So the question is, should we be stopping altogether? Should we be throwing the baby out with the bathwater? And that is my question for you tonight. So let's look at buccal recession studies. Let's look at what's happened. And if we look at some of the studies, Worley 98, Can 2003, DeRook 2008, and Chen 2009, they all showed that there was you can expect about 1 millimeter buccal recession in every case that you do. So with 1 millimeter buccal recession that you can expect, the question is, why does this happen? Now, the reason is that the buccal plate is mostly made up of bundle bone. Now, bundle bone belongs to the tooth. Bundle bone is the bone that is developed from the tooth bud and the periodontium. So there's a very, very thin amount of bone that's on the buccal part of the tooth that doesn't really belong to the alveolus at all. It belongs to the tooth. So on extraction of that tooth, that bundle bone loses its blood supply, it loses its support, and as a result of that, it starts to collapse. And the buccal bone disappears after tooth extraction if it is made up exclusively of bundle bone. And this is the question, is that we don't know how much is bundle bone and how much is alveolus. But Nevins in 2006 showed these wonderful slides where you can see, here you can see the bundle bone intact, and as soon as a couple of months later, you can see the bundle bone absolutely gone. So you can understand why we are getting that 1 millimeter of recession and why we are getting that buccopalatal collapse. It's quite clear from these slides. So let's look at the first myth. The first myth was that implants retain the buccal bone. In Dennison in 93 and Watzek in 95, they made an assumption that if we use wide implants and we support the buccal plate with the implant, that the implant will maintain the buccal plate. Well, we now know Cavani, Botticelli, Araujo, and Sands certainly have done some phenomenal research, and all the studies are quite clear that they show vertical and horizontal bone loss after implant placement after 6 months. You get horizontal ridge changes from about 10.5 millimeters to 6.5. So in other words, it starts off at 10.5 and ends up at about 6.5 with a loss of about 4 millimeters of buccopalatal dimension, which is a fair amount of buccal dimension collapse. We get the vertical loss, as we said, from around 0.2 to 1 millimeters of vertical recession. And it's quite clear that implants do not retain the buccal bone. So that thinking, that controversy is now out of the window. We know categorically that implants do not retain their buccal bone. So the question is that if implants don't retain their buccal bone, and we're doing immediate implants and the buccal bone goes, is stable buccal bone possible? In other words, is it even possible to get buccal bone over the implants? And here you can see a case again, a walkout as we walk in. This is the patient's own crown fitted back. And this is a 4-year post-op case where you can see the type of buccal bone that we've got 4 years post-operative with the cone beam CT. And Cavani in the Journal of Peri and Restorative Dentistry in 2010 made a lot of important stuff, a lot of important discoveries in their dog study, and we'll go through them in the next few slides. So let's look at immediate recommendations. Where can we draw? Where is the middle of the road? And certainly the low lip line where the patient doesn't show that 1 millimeter of recession is the kind of case where one can do immediate placement without any hassle. But I do strongly urge you to discuss this with the patient first, because there are those patients who, although they have a low lip line, they do go and look in that big mirror down at their house, and if they do see that recession, they feel that after paying so much money that they should have their gingival levels at the right height, and they might be a little bit unhappy. So it's definitely something that one discusses with the patient first to avoid any unhappiness afterwards. And here you can see the case. Again, retrofitted old crown. This patient won't come back for any final crown because he's been walking around with that crown for years. And I keep telling him it's going to break, it's going to come off, but it's now 5 years later. And he's happy. He's got the gingival recession problem, etc. But it's not a problem at all because he's got that low lip line we just showed. There are a number of patients that come in with mouths looking like this who have a low aesthetic value, who really aren't there for a Hollywood smile. Certainly these kind of cases, they need to have their caries removed, they need to have their mouths cleaned up, we need to try and show them how to clean their mouths properly. But this is the day-to-day kind of stuff that we work in, and a tooth that needs to be replaced, this tooth needs to be replaced with an implant. These are cases that one quite happily do immediate placement with buccopalatal collapse and with recession, because these patients have very low aesthetic value. Again, discuss it with the patient, but you'll find that with these kind of cases, they want things as simply and as easy as possible because they don't want to come back for further treatment. Thick gingival morphotypes, Evans and Ferris certainly gave us some good studies where they showed that with thick gingival morphotypes, you get far less recession, far more stable tissue. So the thick gingival morphotypes, which is usually gingiva that's thicker than 1 millimeter, is a much more ideal gingiva to deal with compared to thin gingival morphotypes. Thin gingival morphotypes are definitely ones that we do not want to do immediate placement on, because there you are going to, Evans and Ferris showed that you are going to get much more gingival recession, much more buccopalatal collapse in those kind of scenarios. Another place where you can do it is where 1 millimeter of recession is acceptable, and you do get cases we'll see in the next slide where we classify it, where you can actually see that where you've got the gingiva sitting much lower than the adjacent teeth, and where you get 1 millimeter of recession is going to bring it back up to in line with the adjacent teeth. It's an ideal scenario for an immediate placement. An intact buccal wall is absolutely imperative for immediate placement. There are a lot of studies which show that they do immediate placement, and without even raising flaps, they do buccal augmentation with many variety of different things. It's not something that I believe in or would advise. And there are studies, Ferris and Evans in theirs also showed that you get much more collapse of the buccal tissue, of the buccopalatal, and much more recession if you don't have that buccal wall intact. So an intact buccal wall is certainly a very, very important factor. And we can distinguish between between a dehiscence and a fenestration. A fenestration is one that you can do, and it's not within the scope of this lecture to go into that. But a buccal dehiscence is certainly one that we want to stay away from. We also want to maintain the jump gap of at least 2 millimeters, and this is where Covani and Ferris showed that the more jump gap that we have, the better, because what happens is that the more space we have between implant and buccal wall, the more infill of bone that we've got. Whereas the wider that we put our implant, the less space we allow for new bone to grow in. So we want to leave as much space as possible to allow that new bone to grow in from the buccal wall and from the apex to fill up that space to get the kind of scenario that I showed you in the previous slide. When we fill the jump gap, and again, there's a topic of filling the jump gap versus not filling, and again, that's an issue which is not yet decided upon. I'm in the school whereby I try and fill the jump gap as much as possible, so that at least if I do get the destruction of the buccal wall, that I do have something overlying the implant, which is at least white and doesn't give that shine through of metal. One of the most important things is to fill it properly and as far apically as possible. And I often find when I go to other people's practices, when they do that, what they do is they take an amalgam plugger or some kind of fairly large plug and they plug it down. Now what happens is that you never really get the particles down to the apex. And you can see from the slide, what I do is I take a perio probe and I put the material in and I pack with a perio probe. And although it takes me about 10 minutes to pack that buccal jump gap, I know that buccal jump gap is filled from the apex to the top, so that I've got thick, dense synthetic bone in that area to make sure that I support as much as I can. And if I do get resorption, that I do have my buccal of my implant nicely covered with synthetic bone. Another immediate recommendation, which is critically important, which we know from our studies, is that we need to have good primary stability. If we don't have good primary stability, any immediate placement is going to fail. So that is one of the most critically important factors of immediate placement, is that we get good primary stability of our implant. And for that, we need an implant that has good thread design, and we need to use the right sizes, the right diameters to enable us to utilize the bone to its maximum. So the question again is predictability achievable. Again, another case 2 years old, and here you can see another case again with the red arrow showing you the intact buccal bone. Now again, you can see from Covani studies and from Evans that one of the things that they show that's absolutely important is that the implant must be placed more palatal and the implant must be placed deeper. And both the cases that I showed you, we achieved both of that. We placed the implant deeper than we would have normally, in other words, subcrestal of the buccal, and then you can go sometimes 2-3 millimeters subcrestal. And we also place the implant much more palatal, and what that does, it increases the amount of jump gap, allowing the bone to fill in. That's number one. And number two, it takes away the risk of more recession by placing your implant to buccal, which Evans showed quite nicely in his study, that if you do place your implant buccally, you will get far more buccal recession. So palatal placement. We also used a narrow diameter implant as prescribed by your implant company. Now, I say that it's very important that you understand that there are certain implants that you can use, very narrow diameter implants, and it has very much to do with the type of connection that you use. So for this type of system where there's a cone connection, you can use a 3.5 millimeter implant in a high load bearing area. But if you're using an external hexed implant, you cannot go using a 3.5 or a 3.75. You need a 4 millimeter minimum implant in order for the screw to handle the type of stresses and forces that the occlusion is going to give. So please be very aware that you have to still look at what your implant company is prescribing. But the narrowest implant possible is certainly the way that we're going. And here you can see the type of scenario. This is not what we're looking for anymore. That implant that fills up the socket completely, which was Watsek in 95. This is more the type of scenario where we've got that buccal jump gap, where we've got space, where we've got a palatally and deeper placed implant in order to make sure that we get buccal bone right the way up the neck of the implant. We also, Evan and Ferris also showed that we require a thick buccal plate, and I think it was Spray as well in 2000 also showed. Spray showed that they wanted about a 1.8 millimeter buccal plate, and Evans showed that they wanted anything greater than 1 millimeter, and you can see the type of buccal plate that we're looking for, because that is going to give you far less buccopalatal resorption and far less buccal recession if you have that type of buccal plate intact. Let's look at a classification of the gingival level, and here you can see this one is definitely going to get that 1 millimeter of recession. When it's apical, it's going to be even higher, so these are ones that maybe should be not going for immediate placement if the patient has a high aesthetic value. But when it's coronal like this, then that is the ideal, and I just to reiterate again from the slide that I showed you before, here's one that you can, where the gum level is sitting coronal, you can afford to have 1 millimeter of recession to get the gum lines in position. So let's look at the delayed recommendations, which have been put out by Booz and Belser in the ITI Treatment Guides, Volume 3. And I certainly agree with a lot of these, whereby patients with a high aesthetic value, certainly these are ones that we should be very, very careful about doing immediate placement. Should we be placing immediate? And the answer is probably no. Here's where we need to maybe take a step back and put the implant in a delayed approach. The other issue is thin gingival morphotype. We spoke about this from Evans' study, that thin gingival morphotype, you do have more buccopalatal collapse, you do have more recession. So these are cases whereby we want to stand back and rather take out, allow primary healing, and only then go back and put the implant in. Bulbous bone, Nevin showed us in his study that where you've got bulbous bone, the bone is generally very, very thin, which means that it's mostly made up of bundle bone, which means that the resorption, the buccopalatal collapse that you're going to get is going to be absolutely immense, and as a result of that, you're going to get lots of recession, lots of buccopalatal collapse. Buccal bone dehiscence, as we explained before, this is the kind of scenario where, in most cases, what I do here is I do delayed placement and eventually go and do a buccal bone augmentation to make sure that I get good buccal bone over the outside. And Uli Grunder also a very big one for doing this kind of thing, where he insists on getting buccal bone augmentation to try and recreate the 2 to 3 millimeters that he wants to make sure that you get stable buccal bone over the long term. Let's look at the evidence now. Let's go down to the brass tacks, and let's look at some studies and about whether evidence that delayed works better than immediate. And here's a study done by Chen and Boozer. And let's go down to the bottom part here, because of the conclusions that they said, and I'll just read it. It says, similar survival rates were observed for immediate type 1 and early type 2 planars. So the survival rates were the same, but recession of the facial mucosal margin is common with immediate type 1 placement. Risk indicators include thin gingival morphotype, which I've explained, facial malposition, which is Evans' study, where the implant is placed too buccally, and thin or damaged facial buccal wall, where we've got dehiscences. Early implant placement, type 2 or type 3, is associated with a lower frequency of mucosal recession compared to immediate placement. So this is a study that Chen and Boozer did, where they showed that you get a much better stable aesthetics over the long term when you're doing a delayed approach. That was in 2009. Let's go now to Esposito. Now, Esposito did a systematic review in 2010, Now, again, Esposito is somebody that's very highly respected and a very honest researcher, and again, with systematic reviews being very highly rated. And his conclusions were that there's insufficient evidence to determine the possible advantages or disadvantages of immediate implant, delayed or delayed implants. Therefore, these preliminary conclusions are based on few, underpowered trials, often judged to be at high risk of bias. So he's saying that basically we're dealing with cases whereby the people who are judging these cases are maybe not taking their eye off the ball a little bit and not giving us an honest opinion. There is a suggestion that immediate and immediate delayed implants may be at higher risk of implant failure. That's what he's found, and complications than delayed implants. On the other hand, aesthetic outcomes might be better when placing implants just after tooth extraction. And that's pretty much what we've been saying, is that the aesthetics, without a doubt, are much, much better. And I'll show you some cases a little bit later. So there's another bit of scientific data. And another one in 2012 by Van Kesteren. And their conclusion was, this was a randomized control study, which is a good study as well, comparing soft tissue changes following extraction, failed to identify differences between patients treated with immediate and delayed approaches. So in other words, when you do a delayed approach, do you get that much better of an aesthetic result and that much better of a stable aesthetic result over the long term? And they're finding that in this case it isn't. Both immediate and delayed treatment approaches appear to be appropriate following tooth extraction, with the preferred treatment based on factors other than resultant soft tissue changes. So it shows us that our treatment choices were not based on whether there was going to be a soft tissue change, but rather on other factors like single tooth cost, how much treatment they need to go through, etc. So these are very interesting studies which show, but there are no studies at this point in time which show overall what we need. Let's look at now some of the other difficulties that we have is that when you're doing a delayed type approach, they are most definitely far more difficult because they do require far more soft tissue manipulation than they did before. And you can see the type of soft tissue work that comes in where we need to take palatal tissue, we need to do grafting, infold techniques. There's a lot more surgical technique that's required when you're going to do exposure of these implants at a later stage. Here you can see a case that I did. Here's on the right-hand side with the central incisor in the 2-1 area. You can see this is a delayed approach, and you can see the type of soft tissue healing that you have in this area. Whereas just next door is an implant that I placed, and this is about 2 years post-op. This is about 6 or 8 years post-op. And you can see the type of difference that we've got in soft tissue design around the implant that was done immediately versus the implant that was done with a delayed approach. You can see great contours, nice contours, whereas here you can see that there's a disturbance of the scarring of the soft tissue due to the soft tissue procedures that were carried out to do the exposure in this area. The other thing that one has to take into consideration is that you can rebuild the buccal soft tissue. That is possible. Here's a case where a long time ago, it's about 12, 14 years ago, where we had this case that came in with this buccal porcelain, and after soft tissue grafting, we managed to get a very good, favorable result. So even if we do get, and you saw from the other case that we treated earlier, even if you do get the collapse, these things are fixable. They are doable. The problem is that in multiple implant cases, where you've got papilla involved and you allow that papilla to collapse, once that papilla has collapsed, there's nothing at all that one can do to regain that papilla. We cannot rebuild the papilla. We can rebuild buccally. We can even come down a little bit with the buccal margin. But the papilla, once that's gone, it's gone. We cannot, under any circumstance, rebuild it. Now we have to go to pink composites and things like that. And it's a very difficult task for a single implant to rebuild, to do composite in these kind of cases. We cannot rebuild the papilla. In these kind of cases, the only thing that we can do is to build a moustache. So perhaps what we need is a classification, and this is something that we've been working on now for a year in my practice, where we're doing a study to try and look at if a classification is necessary to give people guidance as to when they can do it and when they can't. And this classification comes down to tooth position in the arch. And the type 1 tooth position is where the crown and the root is within the bone envelope. The type 2 is where the crown is inside the envelope, but the root is outside the envelope, and I'll show you examples in a minute, so don't worry. Type 3 is where the crown is outside the envelope, but the root is inside, and type 4 where the crown and the root is outside the envelope. Now if we go to type 1, okay, class 1, here you can see where both the crown and the root is inside the envelope. Now if we look at the studies by Eros, Ferris, etc., Nevins, what we're looking at is we can see that with this type of class 1, we end up with a nice thick buccal bone. And with that nice thick buccal bone, the risk of buccopalatal dimension collapse, the risk of recession is much, much less. So this is actually an ideal case, in my opinion, where we can get immediate placement. The class 2, again, allows us, you can see again, the crown is inside the envelope, but the root is sitting outside the envelope. Now, it's not important to have bone over here because there is right underneath the lip, and it's not really an important area to worry about. But if you look at the top, the buccal bone that we have is still 1 to 1.5 millimeters thick, so it's an ideal situation for immediate placement because we know from our studies that there we're going to get much less resorption. So these are ideal cases where we've got thick bone on the outside. But as soon as we go to class 3, now even though it's a little small, you can see the crown is now sitting outside the buccal bone, the root is sitting inside the buccal bone. But here, when you extract the tooth, you are going to end up with very, very thin buccal bone around the coronal portion of the neck of the implant, and that's where our bundle bone is and where we're going to get more resorption. So class 3 is perhaps a case where we shouldn't be doing immediate placement, whereas class 1 and 2 certainly is. And class 4, again, here you can see the type of scenario where both the crown and the root, excuse me, are sitting outside. Now you can imagine with this type of scenario that when you extract this, you are going to get very, very thin buccal plate, and as a result of that, the buccal plate is going to resorb quickly. You're going to get massive buccopalatal collapse, recession, etc., and a poor long-term aesthetic result. So class 4 again is a scenario whereby we aren't going to place an immediate placement. So this is just a small classification that we are looking at, and we're about a year down the line of our study to do the measurements, and hopefully within another year we'll have all the data whereby we can publish this classification. But it's pretty much what I'm working on now and the way I'm classifying my implant cases. Let's look at some of the other controversies surrounding immediate placement. And this is something which is quite amazing because you'll hear many top implant guys talking about always drill 1/3 up the palatal wall of the extraction socket, and I'll go into a little bit more detail. The other controversy that we can talk a little bit about is you cannot place implants in infected sites. And I want to just go into those last two things before we finish off for this evening. Let's start off with the first myth, is that you always drill 1/3 up the palatal wall. Now, one of the reasons why we always have been told to drill up the palatal wall, and still to this day, a lot of top guys tell us that if you don't, you are going to end up drilling out of the buccal plate. And this is from Booz and Belser's treatment guides, volume 3. You can see this beautiful graphic that they show that if you drill straight down, you'll end up perforating the buccal plate. So what you have to do is you have to angulate inwards and start your hole a little bit 1/3 up the palatal root, so that you put your implant, number one, more palatally, and number two, you also end up putting your apex in bone rather than ending up with your apex coming out. So here you can see this type of scenario, and from the CT, this cone beam CT, you can see that if we drill directly down, we will most definitely go up. So we have to angulate it. We have to go 1/3 up the root so that we make sure that when we drill, we end up with our implant in good bone, rather than ending up with a scenario like this, whereby we go straight down and ending up perforating the buccal plate in the scenario. So this is the rationale behind it, and the rationale is correct. Okay, the rationale is correct, and I reiterate that. However, it is very, very important to know that the root form and the bone form is not the same for every single patient. So we don't have to, in every single case, do this kind of treatment. And if we have a look at this kind of case with this buccal tooth, have a look at this type of scenario that I said, and I say watch out. Because if we start going 1/3 up in this scenario, we are going to end up perforating the palatal bone. This is the kind of scenario that requires direct extension. We need to drill straight down the apex of the root. It is very, very important this, because if we don't do this, we will end up perforating the palatal. So the essential thing here, what this shows us, and here another case whereby we need to drill straight down the root. We don't need to go 1/3 up the buccal plate. The question is, how many of our cases are like this, and how many of our cases require going 1/3? And this is where it becomes essential that you utilize this new technology of cone beam to make sure that you know exactly what type of treatment you are dealing with for your patient. What is the skeletal pattern for that patient? What is the position of the tooth in the alveolus for that patient? Because if you don't know that, you might be making a huge mistake. So please, this is something that since I've started taking cone beam has really opened my eyes with immediate placement. Let's look at the second thing, which is infected sites, and I'm just going to go through some data quickly because I think that's all that's necessary. And you can see here from Crespi 2010, his conclusion was that at 24-month follow-up, endosseous implants placed immediately into extraction sockets affected by periapical infection rendered an equally favorable soft and hard tissue integration of the implants. In other words, there was absolutely no difference in success rate for implants placed in infected sockets versus implants placed in healthy sockets. That was from Crespi, and this is recent research in 2010. And here's another one in 2007. And here you can see a high 1-year survival rate was achieved for immediately placed and immediately loaded implants in the maxilla, despite the presence of infection in location and extracted teeth. And just to cap it off, a third one, this is very recent data in 2012, the Journal of Perio by Marconcini, and their conclusion was that on the basis of the study, implants placed in fresh extraction sockets which were affected by an infection may be valid operative technique which leads to predictable results if adequate pre- and post-operative care is taken. And I think the last sentence in that line, if adequate pre- and post-care is taken, that is the critical thing when one comes to placing implants in infected sites. And it's certainly something that I've been doing for more than 12 years, and I have very little problems with it, and just the same success rate as if I put into healthy extraction sockets. So let's look at what the problems are. One of the problems with dealing with extraction sockets with infections is that it's difficult to remove the infected material, and it's difficult to make sure that all that infected material is gone. The second thing that happens from these studies, which we know, is that primary stability, because we've lost a lot of the apical material, primary stability can be a problem due to the damage of the apical bone, which in most cases is where our primary stability comes from. So because we've lost that apical bone, primary stability sometimes can be a problem. And in some of the early studies where there was a higher loss of implants, it was more likely due to the fact that they did not get good primary stability with their implants. So what recommendations can we give with this type of thing? And one of the recommendations that I can give from my own working is that you need to work with good magnification, with good loops. You need to work with magnification and good lighting and a good suction. And I say a good suction with good thin suction, which can get right up into the extraction socket, because often when I've cleaned out and I've scratched and scraped, and I think I've got an absolutely perfect clean area, what I do find is that when I go in and I look and I suction, there's actually still little bits of oyster that I've left behind, and I can then go and make sure that I've cleaned everything out. So it's essential to use the right equipment. It is also important to ensure that all infected debris is removed, and what I do is after I've removed this, I take a slow rotating burr and I just run it over the area just to number one, freshen it, and to make sure I've left no tissue tags. I don't go drilling it very fast so that I damage the bone. It's a slow rotating burr just to try and help it clean it out nicely. We also need to use longer implants in these cases to make sure that we get primary stability, and in certain cases wider. But remember, I say wider only in certain circumstances where it is not going to impinge on the buccal plate and it is going to allow us to get a good jump gap so that we can allow good bone to grow in. If you cannot do that, then rather take it out and delay it, let it heal, and come back when you can place an implant at a later stage. So in summary, to finalize everything, immediate implant placement is without a doubt an essential part of our treatment. There's no debate about that. We cannot throw the baby out with the bathwater. We do, however, need to be a lot more careful, and we need to choose our cases a little bit more carefully. And we need to make sure that our patients understand that there are certain problems associated with immediate placement. I have to be honest that in my practice, which is a fairly high-profile practice with a lot of high-demanding patients, more often than not, they tend to go for the immediate because it means that they end up with far less treatment, far less costing of treatment, etc., than if I had to do a delayed approach. And the third thing, it is absolutely essential to take a cone beam CT scan with every implant case. We are now in the modern age where this is something that is available to virtually every single person, and if it's not available to you, there's somebody down the road who's got one. Yeah, I don't think there's any more excuse anymore for one making the mistakes of perforating the palatal, perforating the buccal, because we don't know what type of skeletal pattern our tooth is sitting in. Infected sites are not contraindicated for immediate implant placement. I think there's not even a debate anymore. You certainly can do it, and I've been doing it for years with phenomenal success, and I think the data is there to show that we can do it. And again, don't throw the baby out with the bathwater. And with that, I say thank you very much to Dental XP. It's been really phenomenal, and I hope you enjoy the lecture. And I say thank you very much. Have a good evening.